My talk is about the elderly and the importance of the anti-epileptic drugs and how we should do it. And it's sort of a practical lecture on how to treat people who are older than 65. I'm sort of included in this group. I don't feel elderly. It's so weird. And so we have to learn that it's supposedly a very special group. Next slide. You're supposed to turn it. Next slide, please. Yes, and next slide. This will take very long if we, yeah. Anyway, so I hope to tell you about the difficulties of choosing an optimal drug for, okay, take it here. It'll go much faster, yeah. For the elderly, and we want to know how to initiate a drug, how to maintain it, and which is the best drug that we can find, and what about therapeutic drug monitoring? We haven't talked about that at all today. And should we treat the first seizure or not when we're talking about an elderly person? And so Ramsey did a study, the VA cooperative study, back in 2004, and we have a lot of information about the elderly. And if you see here, what type of epilepsy does the elderly have? Well, it's basically, we're talking about focal onset epilepsies. We're not talking about syndromes, absences, etc. This is focal onset. Something is wrong with the brain. So when you get to be an older person, when you get epilepsy, it's not a genetic syndrome. I mean, I'm sure there are exceptions, but it's mainly focalized. Next. And when you manage the elderly, you have a lot of different problems that you have to think about. And it's not just epilepsy. And of course, this is about every patient, even the young and the old and the in-between. But anyway, it is, you have to especially think about pharmacokinetics. This is something that many people forget when you combine or when you, because all of these people have many other drugs. They're not epileptic drugs, but there are many other drugs. And when you add a drug, what are you doing to their other medications or other health conditions, and what's happening to your anti-epileptic drug? What about all those side effects, comorbidities, and everything else, the family, everything? It's a big problem when you're treating the elderly. Next. So in the first seizure in the elderly, so this was a hospital-based study that I wanted to tell you about. I wanted to see it a little bit better, but okay, we'll forget about that one. And this was looking at patients with the first seizure between 2000 and 2011, and there was 138 of the people who were elderly. And what it's interesting is comparing what was the risk factors for the second seizure. And it was interesting that it was not age. So an older person has the same risk factor of getting a second seizure as anyone else. We're not so strange. There's no special thing in that. It's if you have a focal onset seizure, if you have epileptic abnormality on the EEG, if you have a first seizure in sleep, and if you have remote symptomatic epilepsy, it's the same as for the normal adult population. Next. So when we're treating the elderly, you have to think, this is an old slide, but I think it really is something that I'd like to show almost every time, because we always must remember these factors when we're choosing an anti-epileptic drug. Choosing an anti-epileptic drug can be based on rational polytherapy, but we also need, it's an art form. It's an art form to look at the patient and see which combination do you really think will work. So, I mean, one would have to vote for the fact that rational polytherapy is a good idea, but it doesn't really matter when you see the patient. But the co-medications are important. In an elderly person, first thing you have to ask is, what are all your other drugs you're on? The second thing you have to think about is, well, the drug I want to give them, where is it metabolized? What is the pathway? And what is the pathway of all those other drugs? And are they going to meet and cause big problems? Next. So this, you've seen another form of it earlier. It's just to show that we have many different mechanisms of action of our drugs. And so we have to also think about the mechanisms when dealing with our patients, because it's not only mechanisms of action of epileptic effects, it's mechanisms of action of the side effects. What are the side effects of sodium channel blockers? What are the side effects of SV2 action? What is the side effect of AMPA? And when you give these drugs to the patient, that I think is, turns out that side effects are the most important aspects when giving new drugs to patients. Next. So this is just what you know, that you have the associated medical disorders much more than in a regular adult population or children. You have all these polytherapies with numerous different types of drugs. You have different drug-drug interactions. But then the quality of life differs from the other population. Older people have other needs, and even driving is very important. If somebody is driving and has a seizure and they can't move around so easily and they're stuck out in the country, well, this is a terrible thing for a person to not drive, because they can't walk to the bus either. They're maybe physically handicapped. Memory impairment. I tried to do an elderly study once. I couldn't do it because my patients couldn't remember to take the drugs, or they took it all different ways. So adherence is extremely important. How do you get patients to swallow their drugs and take the right dose? And if they take the right dose, or maybe they're taking more, you get dizziness, and then you get falls. And once the patient falls and breaks something, then it's a devastating effect for their whole quality of life, and they may never recover in their mental capacity or physical capacity if they break their hip. So falls are something that we must never forget when we're writing that prescription for an older person. Next. So here is the main evidence-based study for elderly people, and this was the Ramsey and Rowan study, Rowan and Ramsey study, the VA cooperative study. And this was the best study so far in elderly, because they had a lot of patients. They had 593 patients. It was double-blind, and they were giving gabapentin, lamotrigine, or carbamazepine. Note, carbamazepine not slow release. Now, today it's not okay to give a drug, carbamazepine, that's not slow release. You must do that because this study shows it actually. So what they found was that gabapentin and lamotrigine were tolerated better than carbamazepine, so that the guidelines, the ILA guidelines from 2006 say that carbamazepine and gabapentin are better drugs than carbamazepine. I mean, lamotrigine and gabapentin are better drugs than carbamazepine because of this study. However, next, and here you just see that carbamazepine, which is a blue line, shows worse tolerability than the gabapentin and lamotrigine. Next. And so in the next slide, yeah. Then there was a study by Seizure in Norway. Unfortunately, it was only 193 patients, but they were comparing lamotrigine and carbamazepine slow release. And there was no difference. So with slow release, it was as tolerated as lamotrigine, and it had the same efficacy. But it didn't reach up to the high evidence level because the amount of patients was not enough, so the power was lower. Next. So there have been other studies in the elderly, not that many, but still, looking at levetiracetam and carbamazepine. And this was just 128 people. But there was no significant difference between the two. And lamotrigine and carbamazepine in a double-blind study, a smaller study, was also no difference in efficacy. And then there's a zonisamide study comparing that, and I mean zonisamide and placebo. And zonisamide was also a good drug. So keep going. And then we have the study of brivaracetam in elderly, which is also promising. So what am I saying here? I'm saying, well, there's really no big difference in the drugs that you're going to use. It's a side effect profile that becomes important. And we're going to talk about more of that because I think that's the difference with the elderly. You can pick any drug, they will react the same way as any other. When you reach 65, you don't all of a sudden change. Your brain doesn't change that you tolerate, that you have effectiveness for different drugs. It's the side effects that count. So next slide. And so if you look at the epilepsy treatment in older people, and in this study by Menachem, you see that carbamazepine, slow-release, lamotrigine, levetiracetam, this is retention, talking about side effects. And so levetiracetam seemed to be somewhat better, not different from lamotrigine, but from carbamazepine. So carbamazepine is sticking out there as a drug that causes quite a few side effects in the elderly, probably because of their co-medication and interactions. That's sort of this pattern that we're seeing. Next. And so here is a study to look at the effects of lacosamide in patients that were either over 65 or under 65. And we'll go to the slide, next slide, and you will see that patients who are older, they have often other reasons for their epilepsy. It's either a tumor or stroke or small vessel disease, dementia. These are more of the important reasons for having epilepsy. And these type of reasons are more sensitive to the anti-epileptic drugs than people who are younger and they have focal onset seizures because of injury or dysplasias, etc. So you see here in the patients who are over 65 years of age with lacosamide, then you have 81% who are responders compared to the 70% of the general population. So this is interesting that maybe smaller doses, maybe our patients who are elderly do respond better, and that's my clinical impression anyway, although I can't prove it in a study. Next. So our choice of these drugs depends on metabolism. How are they metabolized? And without knowing it, if you just write out a drug and give it to the patient without thinking about the metabolism, you can get into serious trouble. And so it's important to remember the cytochrome P450 enzymes. And as you see, the main ones are these 2C and 3,4A, and the older drugs that we have are metabolized in the liver. And a lot of the newer drugs, as you see, the black ones there on the side, those are the ones that have very little metabolism in the liver that are safer to use for your patients. Martin doesn't think so. No? Why not? No, but they are safer. I mean, come on, if you use, okay, now maybe, what? Yeah, but you have, okay, look, lamotrigine can, the contraceptive pill can affect lamotrigine, but we're not talking about that. There are some interactions, for example, perampanel. If you give it to a sodium channel blocker agent, you will have a lower blood concentration. But I'm talking not about combinations of anti-epileptic drugs. I'm talking about combinations for cytostatic drugs or warfarin or all of these other drugs that the patients will have. So basically, it's negligible or no side effect. These are at least safer than the carbamazepines of the world. Next. And so if you look at the pharmacokinetic profiles of these drugs, looking at oral absorption, which is less in the elderly, pharmacokinetics, how much protein binding, how is it eliminated? Patients have less kidney function, and so you can get accumulation, for example, of levetiracetam in the blood if you have low kidney clearance and drug interactions and administration. You find, unfortunately, vigabatrin is really high up. When we were developing vigabatrin, we said this is the best drug. It really didn't have any interactions. Unfortunately, we can't use it today because of the permanent peripheral visual defects that you can get from vigabatrin, but it's still pharmacokinetic. If you're going to be honest, is way up there as a good drug to use, but not really, so don't use it as a first-line drug. Anyway, lacosamide and levetiracetam are very easy drugs to use in a pharmacokinetic perspective anyway. So that's just something to think about in the elderly. Next. So we made guidelines way back in, these are the updated ones in 2013, and next slide, just to show you the focal onset seizures in adults, looking at comparative non-inferiority studies of carbamazepine compared to levetiracetam, zonisamide, now eslicarbazepine, and lacosamide. There is no superiority of any of those drugs with each other. They're all at the same level. So nobody can beat carbamazepine in its effect, but well on its side effects profile. And then in children, we have, next slide, press again, yeah, and then in the next slide. And in the elderly, when our guidelines stopped, we had only gabapentin and lamotrigine, but I think that most drugs would be effective if you don't have the side effects. Next. And so here are these studies, and this is in adults looking at the head-to-head, and you see levetiracetam and carbamazepine slow release, same with zonisamide, lacosamide, pregabalin compared to lamotrigine showed that lamotrigine was better in any way than pregabalin. This is not really a drug to use in monotherapy. Next. And here is looking also at the levetiracetam versus carbamazepine, an important principle here. What do you see here? You know what you're looking at. You're looking at the doses of 1,000 milligrams of levetiracetam or 400 milligrams of carbamazepine were really very good. And increasing the doses didn't necessarily bring a lot of people over to seizure freedom. And the same with zonisamide and carbamazepine. 300 milligrams of zonisamide was just as effective as 600 milligrams of carbamazepine. But if you look at the carbamazepine there, maybe 800 was somewhat better than looking at the levetiracetam group of 400 milligrams. But the best thing for elderly people is start low, go slow, know that the lowest doses are effective, and in the elderly, low doses will help because they have lower elimination, and so they tend to have higher blood concentrations with the same lower dose. Next. So here is my take on the possible rational combinations, and you have the voltage-gated sodium channel blockers, and why I don't combine them together in the elderly is that they'll get dizzy and they'll fall. Because dizziness is the biggest problem with the sodium channel blockers, and you give them dual therapy together, and you take a risk with these very vulnerable patients. And then combinations I have in green, brivaracetam and perampanel, because these are the new drugs. Perampanel causes a lot of dizziness. However, you have to give it very, very late at night when the patient takes it and goes to sleep, and then usually they wake up in the morning and the dizziness side effect tends to disappear. But if you have someone with prostate hyperplasia and is going up every 2 hours to go to the bathroom, then you have a problem. And I would not recommend perampanel for those patients. Next. So polytherapy in the elderly, most elderly are only treated with polytherapy, but only one of them is an anti-epileptic drug. And this is to show you something. Next slide. Here is a study. This is only 2 patients. Next. Yeah, and they were given simvastatin. And you can see the higher bar is simvastatin given just as a monotherapy. And then when you combine it with carbamazepine, the simvastatin level is cut in half. And if anything, take that home with you. When you're giving a drug to an elderly patient, think about maybe they need their simvastatin, maybe they need, their warfarin or whatever, and you have to take blood concentrations, therapeutic blood monitoring on all of these drugs if you're going to choose a drug like carbamazepine, which is extensively metabolized in the liver. Next. So here are the type of side effects that we have to think about. Dose-related, pharmacodynamic interactions. Then you have these long-term ones, teratogenic ones, not important in the elderly. Thank goodness we don't have to think about that. Some patients maybe they're going to get in vitro fertilization at the age of 60, but otherwise. Next. So to minimize the risks, you have to gradually start low. And so here are examples of new drugs with slow titration, increases tolerability. What do you see there? It's every drug. Every single drug that you touch, you should start slow and low and creep up very slowly unless you're absolutely required to do something very fast. Shouldn't be in a hurry because you can probably end up with a very low dose and have a seizure-free patient with no side effects. Next. Then you have idiosyncratic side effects. Don't forget them. They're unpredictable, and they can occur in elderly as well as young patients, and they can be very devastating. I'm very surprised. I see this also in my clinic that people that get a rash with lamotrigine. Well, I get very scared when I see that. But people can re-challenge these patients, but I'm not willing to take that risk. We have 24 drugs. I would change drugs. If I see a rash with carbamazepine, I would immediately take it away. I have a great respect for these idiosyncratic allergic reactions. Next. And of course, and so here are just Stevens-Johnson syndrome you can get with almost any of our drugs. And never say to the patient, well, you have this rash, but it can't be this drug. We have to be humble and always say, well, maybe it is this drug, because you can get into great trouble. Next. And so we have screening programs for the HLA mutations, especially for carbamazepine and oxcarbazepine in Asian people. And so therefore one has to think about taking that test if you really need to give them carbamazepine. But why give them carbamazepine when we have so many other choices today? So people who are in the risk zone of getting rashes and allergic reactions, don't go there. Don't go to the carbamazepines and the phenytoins. Next. So you have to do TDM, therapeutic drug monitoring, in certain cases. And the therapeutic drug monitoring, you have these protein bindings of the anti-epileptic drugs. Other drugs, you need to look at the absorption elimination. The next slide. And so you do the therapeutic drug monitoring when you've reached your goal and you want to see how high the blood level is if the patient isn't seizure-free. If the patient has side effects, you need to take the TDM. If you have breakthrough seizures, every single time you're adding or taking away a drug that can potentially interact with the drug that you have, you've got to monitor this. And you have to change, anytime there's a change in the health status, or to monitor adherence, are they really taking the drug? Next. So the effect of age on AED dose ranges is the window of opportunity gets smaller and smaller. You can use raising the dose causes side effects much earlier than in a younger person. And so you have a very small therapeutic window the older the patient gets. And that's why you go slow and you start low. Next. So this is when you should use non-inducing anti-epileptic drugs to avoid the systemic chronic side effects, to avoid drug-drug interactions, and when elderlies are taking multiple medications, and in people with a risk of osteoporosis, because as soon as you get a drug that's metabolized in the liver, you have an increased risk of interactions with vitamin D and osteoporosis as a result. Next. So, if you have the risk of drug-drug interaction, you choose a drug with minimum risk. And you avoid carbamazepine with warfarin, omeprazole, which is a very common drug, antibiotics, as well as chemotherapy. Just don't give them carbamazepine if someone has cancer. And then you add on AEDs that are not expected to interact. And you have to control, if you're going to give carbamazepine, control for hyponatremia. Very important, because this is really a big risk. And the same for oxcarbazepine and even the new eslicarbazepine. You're not out of the woods with the new eslicarbazepine. Next. So you match the choice of drug to the patient's seizures and their characteristics. You have to talk to the patient. Can't spend 5 minutes with them. You have to see the holistic view. And you have to think about these risks for hyponatremia, dizziness, cognitive disturbances, which can ruin their whole life. The cognitive disturbances, behavioral side effects. Next. And start slow and try not to use enzyme-inducing AEDs or even valproate, which can give valproate encephalopathies and cause dementia and Parkinson-like symptoms and tremor. So you just shouldn't really use it for the elderly if you can choose something else. And you have to monitor the side effects, communicate with the family. You know, I usually say no news is good news. If you have any problem, you better call, because how will we know? Next. And so epilepsy is common in the elderly with comorbidities. You have drug-drug interactions you must always think about, and use TDM when in doubt. And of course, as we conclude every manuscript that we write or every talk, you need to do more research. Thank you very much.